Talk today about the toddlers in the Middle East, challenges and opportunities. And that's why I'm not wearing a tie, Muhammad, like you, because I can't get a tie. It can't pass to this place. I'm now in the north coast of Egypt with my shorts, sitting, making the talk in this lovely atmosphere. First, the disclaimer, the conflict of interest. Definitely yes, because speakers, theoretically speaking, they should receive honorarium for the time and effort they spend in making these presentations. On the other hand, there is no conflict of interest whatsoever because I do not allow any sponsor to interfere in the scientific content of my talk. So any words I say or anything in the slides is referenced, and I am totally responsible about what I'm saying. We will pass through these 6 points, hopefully fast. First, who is the toddler? But before I talk about toddlerhood, I want to remind you that breast milk is a real magic. That's the composition of the breast milk. You can see it's a lot of ingredients that we cannot even make half of them so far. I'm sure that you can't read all of these, and it's not intended to be read. It's just to see how wide is this. And these components do not work in isolation. In fact, they work in an orchestrated manner. So that's why we all believe that breast milk is the best and should be encouraged up to 2 years and beyond. So whether you go from the religion, from the science, from the common sense, from the components of the milk, from the orchestrated actions of its different ingredients, from its variability, we will go to breast milk. That's why the WHO have said that exclusive breastfeeding is recommended up to 6 months of age, and then it needs to be continued with appropriate complementary food up to 2 years and beyond. Unfortunately, our dreams is sometimes bigger than reality. Anybody knows who is this guy? I'll tell you. This is the very famous poet, one of the greatest, if not the greatest, Abu Tayyib al-Mutanabbi. He has a qasida or a poem called بما التعلل لا أهل ولا وطن, and this is in Arabic. ما كل ما يتمنى المرء يدركه تجري الرياح بما لا تشتهي السفن. It's a very famous, it became a proverb from Abu Tayyib al-Mutanabbi. And that's the real fact. When we go to global breastfeeding data, we will find that only 43% of babies continued exclusive breastfeeding till 6 months. This means that 57% did not continue. And that's why in the Global Nutritional Targets 2025 by WHO, they aim to increase the rate to at least 50%. So even in their dreams, they don't dream to reach 100%. What does that mean? Means that there are kids who need formulas. Now let me take you to the journey in the toddlers. According to the Oxford Dictionary, toddler is a young child who is just beginning to walk. But when you go to the CDC for definition, toddlerhood is the 2nd and 3rd year of life. Then comes the preschool age, which is from 3 to 5. However, all the statistics when it comes to any diseases or nutritional disorders, take them all together in one box from the end of the 1st year till the end of the 5th year and the beginning of the 6th year. What are the specific characteristics of the toddlers? We have 4 places where the toddler is unique or more or less have special characters. Number 1, the growth in weight and height, very fast. In brain development with subsequent cognition and language, in motor development, in vision, and in the immune system development. That all happens, and let us see them one by one. If you go to the weight, the baby is born almost 3.5 kilograms. he is doubled almost by 4 months of age. He is tripled by the age of 1 year, and 4 times by the age of 12 years. So if we are going to apply this fast growth pattern in adults, that's me. After 4 months, I should be like this. After 1 year, I should be like this. After 2 years, I should be like this. So if we grow as fast as the toddlers, it would be a disaster. In 2 years, you can be that fat guy on the right side. When we go to the height, the baby average is 50 centimeters tall at birth. Then he gains 25 centimeters in the first year, another 12 centimeters in the second year. And look what happens. The height at the age of 2 years is almost half of your adult height. So if he's 85, it's expected that he will be 170 as an adult. Of course, that's approximation, not by the book, not 100%. When we go to brain growth and development, you will find that the brain grows very fast. All these statements are true. The brain doubles in size in the first year, but at the age of 2 to 3 years, it reaches 80% of its adult size. And also at the same age, it has twice as many synapses as it will have in adulthood. You will ask me, where the other synapses gone? I'll tell you, they disappear by a process called pruning. If you don't use it, you lose it. So the toddler have more synapses than the adult. Also, the immune system develops fast at this. It's maturing. This toddler is at high susceptibility to infections due to his immature system. His maternally acquired antibodies disappears by this age. He's highly exposed to new environmental and food pathogens, and also his intestinal microbiota profile shifts from the bifidogenic dominant to a more diversified adult-like flora. What about the eating behavior of the toddler? The appetite decreases and he becomes increasingly autonomous. And he is suffer from gradual transition to table food and feeding, and here feeding difficulties starts, and if improperly dealt with, they may persist. Also, they have smaller tummies. The toddler's tummy is 5 times smaller than that of the adult. This would be a problem, you know why? Because his nutritional needs per kilogram of body weight is much higher. Look to this, that's 1 unit. 1 unit means maybe 1 gram, maybe 1 milligram, maybe 10 grams, whatever. That's the adult's requirement per kilogram of body weight. And if you look, for example, for the slink requirements, he needs 3 times per kilogram of body weight more than adults. Iodine the same, vitamin D 3.5 times per kilogram of body weight, iron more than 5 times, calcium 4 times, protein 1.4, and energy 1.6. How this is calculated, I'll show it to you. For example, vitamin D. A toddler needs 600 international units per day. An adult who is 70 kilograms needs 1,000 international units per day. Then the toddler needs 3.5 times the adult regarding vitamin D. Now we can the same if we go to the calcium, 4 times. Toddler's needs is higher per kilogram of body weight. For iron, 5 times. And that's how it's calculated. So not only have a small tummy, but also his needs per kilogram of body weight is much higher. Surprisingly, that these young children in the so-called Western advanced countries also suffer. And this is the European Food Safety. European young children often have suboptimal intakes. In the West, the rich, the more advanced, than what the situation would be in our country. So they say in the EU, the kids take more protein, more energy than they should, while they have too little of iron, vitamin D, DHA, iodine, ALA. Now, we have nutritional challenges at this age group, and we have 4 points. It's quite difficult to achieve good optimal nutritional supply because the toddler is because of the nutrition, because of the parents, because of us. For the toddler, we mentioned fast growth and development, high demand, poor appetite, small tummies. For the nutrition, there is decline in milk consumption, definitely. There is a trend towards increased consumption of cow's milk, non-diversification of food and bad eating habits. The parents lack awareness about these characteristics and the needs of toddlerhood, and doctors do not focus on nutrition many times due to time constraints because we need to give time. If we don't give time during the medical visits, we cannot discuss with the parents or the mothers about the proper nutrition of these kids. So due to these challenges, we have problems with macro and micronutrients. These are the macro and these are the micronutrients. As we all know, the macronutrients, carbs, proteins, fats, and water. The micronutrients are all the vitamins and minerals. The macronutrients are usually required in large amounts in grams. They're essential for body growth, repair, and developing new tissues. With the exception of water, their main function is to provide energy. While the micronutrients, we need them in minute amounts. They are important for the vitality, for the healthy development, for the well-being, for disease prevention. They have nothing to do with providing energy, and when they are absent or deficient, we use the term hidden hunger. So macronutrients and energy deficiency and excess, let me remove this guy who is the normal. We can have many of nutritional syndromes, from obesity to stunting, passing to wasting and underweight. While micronutrient deficiencies, we have anemia, rickets, scurvy, cirrhosis, stunting, but also low immunity with recurrent infections and also impaired cognitive development that may lead to permanent deficits. And if we look to these data that's accessed this month about the nutritional condition, look to anemia, for example, in children under 5. Most of these anemias, by the way, are iron deficiency anemia. More than 83% of Yemeni children having anemia. Sudan is 57%. The best is in Lebanon, 25%. In Egypt, 31%. You can look at your country and you can see that a lot of our children, preschool children, including the toddlers, are anemic, which is not accepted. Go to vitamin A deficiency, which is described by the WHO as the leading cause of preventable childhood blindness and needs the high dose supplementation that's needed. It reduces the all-cause mortality from 12 to 24% for those who take it, and it's mainly a public health problem in sub-Saharan Africa and South Asia. But look to our countries. Vitamin A deficiency in children from 6 months to 5 years, that includes the toddlers, less than 10% in Egypt, Libya, Tunisia, Emirates, Saudi Arabia, and Oman. From 10 to 19% in Algeria, Morocco, Iraq, Jordan, Syria. And look to Sudan and Yemen. It's very alarming. Vitamin A deficiency, not only blindness, but also increased risk of infections, as we will see later. Vitamin D and calcium, they are definitely closely related. Anybody knows the term of media darling? Media darling is a term used to describe a celebrity who is popular and receives frequent and very favorable attention in the news media. This is the media darling. Mo Salah, of course, my favorite. And vitamin D is described as a media darling. That's not my description, by the way. That's the American Academy of Pediatric News since 2017. They describe that vitamin D is a media darling. In addition to its major role in bone health, it has been touted. And when I heard touted, excuse my bad English, what is touted? So I went to the dictionary. To toot means to sell something typically by direct and persistent approach. So they always sending the message to us that vitamin D prevent or cure ailments from depression to infections, even diabetes and cancer. And that's the statement of the American Academy. It's easy for pediatricians to be swept in the whirlwind of vitamin D enthusiasm. What do they mean? This دوامة زوبعة في الحماس for vitamin D. Infants need 400 international units per day, but toddlers and children, adolescents need 600. So the toddler needs more vitamin D than the infant. And the recommendation is that infants are exclusively breastfed or getting less than 1 liter of formula daily should be supplemented with 400 international units starting from the first few days of life and continue until they are 12 months. What after 12 months? The older children and the toddlers, they are notoriously unpredictable eaters. Notoriously means well known to be unpredictable eaters, so they may need also supplementation of vitamin D. Look to the sun and vitamin D. We all believe that definitely ultraviolet rays, B rays can produce vitamin D in the skin. But look what the American Academy says, consumption of vitamin D through diet is the most dependable way to ensure adequate intake. That's a very recent tweet from the American Academy of Dermatology. They say just one sunburn during childhood or adolescence can double the person's chance of developing melanoma later in life. So the picture is from the American Academy of Dermatology. Keep your baby protected from the sun. So in one way, yes, ultraviolet rays from the sun will produce vitamin D. In another way, they keep telling us don't, and that's the recommendation. Keep the baby in the shade, dress him in some protective clothing, sunglasses, wide-brimmed hat, minimize sunscreen in infants below the age of 6 months. Remember to reapply these sunscreens every 2 hours for those after swimming or sweating, because there is water resistant but never waterproof sunscreen, and stay hot and hydrated, stay safe and hydrated. Oh, that's the recommendation of the American Academy. If we follow these recommendations, then it's unlikely that we can depend on the sun as the source of vitamin D for infants and toddlers. And by the way, this is not new. That's American Academy since more than 20 years that said this. When they go to nutritional records, they mentioned about the doses of vitamin D, but they also stressed that you need to consume at least 500 milligrams of calcium daily throughout the dietary supplementation. So vitamin D doesn't work in isolation away from the calcium. Look to the GCC countries, all of them in these data, which is published, by the way, in 2019, just last year, all of these countries having more than 80% deficiency in vitamin D. And this is, for example, in Oman. I'll remove the adults and look the boys. Omani boys 40%, boys at the age of 9 to 10. Omani girls 80%, and children below 5 years are almost 5 or 7% vitamin D deficient. I'm not happy with the number of boys and girls, but I'm happy with the Omani National Nutrition Survey. This is a review by Marlene Shahtoura from Lebanon, and says hypovitaminoses D is so prevalent in MENA regions and high doses may be necessary. So who needs more calcium, infant or toddler? Look, infancy, early infancy needs 200 milligrams per day to 60 milligrams in the second 6 months, while toddlers need 700 milligrams. So toddlers needs much more calcium than infants. Who is more vulnerable to calcium deficiency? Definitely the toddler. Why? Because the infant depends on the milk most of his time. So, and the milk is an excellent source of calcium. And we all know about vitamin D supplementation. So when weaning starts for the toddler or earlier a little bit, milk consumption drops, cereals have high phytates that interfere with the calcium absorption, and diversification may be limited. So toddlers and older infants can be calcium deficient easily. I'll go then to the macronutrients in our area. And first I'll take stunting. The global prevalence of stunting, you can see it on the top right box, 21.3. Look to our countries. sorry, it's, yes. In Sudan and Libya, while the global is 21, in Sudan and Libya and Yemen, more than 30%. In Egypt and Syria, from 20 to less than 30. All of our countries having some degree of stunting, maybe better. Look to the Middle East in general, 14.3% of children under 5 in the Middle East are stunted. But the overall global performance and Middle East performance is good regarding stunting, with significant decline globally by 34%. The number again declined from almost 200 million in 2000 to 144 in 2019. Unfortunately, the poor are suffering more from stunting than the rich, almost double, poor and the rich. So if we go to wasting, the global wasting is 6.9% in children under 5. Now you can see more than 15% in Sudan and Yemen, 10 to 15% in Libya, Saudi Arabia, and Syria, 5 to 10% in Egypt and Oman. So again, we suffer from wasting in our countries, and the overall is 6.7% of our children are wasted. When we go to overweight globally, the 5.6% are overweight. But look to the disaster. Egypt, Libya, Tunisia, and Syria, more than 15% having overweight kids above the age, in age under 5. Algeria and Morocco, 10 to 15%. From 5 to 10%, Saudi Arabia and Iraq. So a lot of our countries suffer. In the Middle East in general, we are the top ranked UNICEF region in childhood obesity, 11%. That's number 1 in all the regions. There is a big failure in handling the overweight children over these 20 years. There is an increase. You can see it on the right side, and you can see it also on the very left side in the Middle East. Since 20 years, they were 8.9%. Now 11% of our kids are overweight. So that's an example of failure. So the summary so far: worldwide, there are nutritional deficiencies for toddlers and children under 5. That's still a major problem. The same applies to our MENA region and the Gulf, and something must be done. And that's just to review the numbers in just one slide. We have many anemias, many vitamin A and vitamin D deficiencies. Now, let's go to the basic principles of toddlers feeding and nutrition. It sounds easy. We need to supply all nutrients in the right quantities and qualities, and encourage healthy eating habits and deal with probable feeding difficulties. It's very easy. Sounds easy, but the devil comes in the details. كما نقول الشيطان يكمن في التفاصيل. So we know that the toddler have specific characters, have nutritional challenges, have deficiencies, and simply we need proper nutrition. Let me take you to these 5 points about proper nutrition and feeding. Does the toddler need milk? The answer is clear, yes. It's an excellent source of calcium, protein, energy, by the fats and carbohydrates, and some vitamins, particularly A and B12. The question is, which type of milk? Most standard milk formulas are cow-based. Because of which one? Is it the composition that's very close to human milk, or is it because cow's milk is rich in calcium, or because it's rich in iron, nucleotides, DHA and DHA, or because there are plenty of cows and cows produce plenty of milk? And the answer is that simply we get the milk from cows because there are plenty of cows and cows produce plenty of milk, not because that's an excellent quality, because it's designed for the baby cow, not for the human baby. And the question comes, why? This unmodified cow's milk is not ideal for infants and toddlers because it has too much of protein, of casein 2A, of saturated fatty acids, but also too little of iron, iron bioavailability, zinc, essential fatty acids, vitamin E. And look to the iron content and bioavailability. you can see that iron content in cow's milk and human milk, they are not so different. But when you look to the mean of the bioavailability, 19.5% in cow's milk, while 48% in human milk. So it's a problem of bioavailability rather than content. And that's why it's very famous in milk formula that they add vitamin C, because it's well proven that vitamin C increases the absorption. Many studies, many confirmation that vitamin C increases the absorption of iron. And that's why the 10-to-1 ratio, 10 vitamin C, 1 iron, is very common in the proper milk formula. Look to the Espegan 2017. It's clear cow's milk is a poor iron source, provides excess protein and fat and energy when used. It should not be used as the main drink before 12 months. Although small volumes may be added to complementary food. The question, what do they mean by small volumes? They didn't answer. But the answer may come from a previous report from the Espegan when they take for the toddlers, intake should be limited to less than half a liter a day of unmodified cow's milk. And they mentioned the term unmodified cow's milk should not be fed as the main drink, yes, in infants, but intake should be limited to less than 500 ml a day in toddlers. So which type of milk would be recommended? There is something called gum or growing up milk that's specially designed for toddlers. It gives the calcium, it gives the proper protein, the proper energy, and always fortified with something, many of these vitamins, whether vitamin D, A, iron, zinc, C, selenium, prebiotics, and others. And these are examples of gums. The Nido 1 Plus growing up formula, the Nan OptiPro growing up formula, the S26. And if I take this, you can see that it's fortified with iron, zinc, selenium, A, C, and E vitamins, and DHA. But you have to be clear, and I have to be clear, there are many gums in the market, and the ingredients gum is not one composition. They differ from one manufacturer to another, and the ingredients of a gum can be different in your country than my country. That's why we always need to check for the ingredients of the different gums in our own countries, so that you can choose what you want to choose. You will see the different ingredients of each gum. And the question can come, are our toddlers going to die if they don't use gum? The answer is, of course not. It's all about added value. It's about fine tuning. When you have better composition, you expect better growth, better development, better immunity, less nutritional deficiencies and their consequences, and long-term health impact. So with all these biofactors or nutrients given to based on a cow's milk, then not unmodified, it's modified, and we can make the gums. And I'll talk shortly about the immunonutrients and look to the EFSA statements. If we follow the guidelines of micronutrients, that contribute to the normal function of the immune system. Iron can affect immunity, whether lymphocyte-mediated immunity and phagocytic immunity. And you'll be surprised. This immune deficiency, of course, will lead to more infections, and it can be corrected if iron deficiency is correct. So remember the 3 I's: iron, immunity, and the infection. Vitamin C. We always think that vitamin C is simply for the epithelium, and no, it has a lot to do with phagocytic activities and differentiation, proliferation of B cells and T cells. And importantly, it's rapidly utilized during infection, so it has a lot with the immune system. Vitamin A, again, we always think it's just for the epithelium and mucosa. No, it affects cell differentiation, maturity, immunologic functions, in innate immunity. And if vitamin A deficient, then infections are worse, and supplementation of vitamin A could reduce mortality but by up to 30% of preschool children. Vitamin D, yes, it's important for bone, but there is a lot of studies about its effect on innate immunity. As you can see, macrophages, monocytes, enhances chemotaxis, phagocytic capabilities, antigen-presenting cells. It's very important for suppressing the autoreactivity, vitamin D, through the antigen-presenting cells and through the effect on B cells will reduce the development of probably autoimmune or autoreactive disease. And vitamin D receptors do exist on both T and B cells. So it works in the innate and adaptive immune system, particularly what they call down-regulation of autoimmunity. Zinc, the second most abundant trace metal after iron, and deficiency affect many organs, particularly the immune system. Zinc deficiency induces immune dysfunction, innate and adaptive immunity, and zinc deficient individuals are more susceptible to infections, and many of the negative outcomes can be reversed by simply zinc levels correction. I'm sure nobody knows this guy, the Swedish scientist, John Jacob Berzelius. By the way, he is the one who discovered the selenium, and he was awarded the position of nobility in 1818, and then he's awarded the baronetcy in 1835. So, by the way, Nobel man زي اللي هو طلع في فيلم الأيدي الناعمة النبيل عماد اللي مثله أحمد لطفي, a Nobel man. So, selenium, it works via selenoproteins affecting both innate and adaptive immunity. By the way, since it was discovered for 150 years, it was considered to be toxic for humans and livestock until they discovered that it has a great effects in the immune system, and deficiency will lead to immune incompetence with increased susceptibility to infection and maybe cancer. And you see, if you have deficient selenium, reduced adaptive immunity, more inflammation exacerbation, and probably one of the parts of lower immunity in old age is declining selenium status. Now we'll go to the nutrients for the brain and cognitive development and for retina and visual development. By cognition, we mean, of course, there are hundreds of definitions about cognition, but attention, memory, thinking, learning, and perception, that's all cognition. And iron is important for cognition. We all know that it's important cofactor for some enzymes, particularly the happy chemicals, dopamine and serotonin. Iron deficiency and iron deficiency anemia have been conclusively linked to deterioration in psychomotor development and impaired cognitive performance, and can lead to learning disabilities. And unfortunately, there is evidence that indicates that this effect can persist through adulthood. You may say, but these references are 10 years ago. That's a reference that will be published in August 2020. It's published online only, and look to this reference and the conclusion that early childhood body iron status at 7 and 15 and 24 months have been associated with verbal and performance and processing speed components at cognition at the age of 5 years. So it can persist, the negative impact can persist, and if you correct it, if it was corrected so early, then you will have a better performance. When we go to the DHA and DAA, the building blocks of the phospholipids in the brains and retina, and look to the DHA, that's documented. Improved problem solving at the age of 10 months, higher mental developmental index at 18 months, faster processing information at 6 years. That's why it became mandatory addition to infant formula. So DHA will always be there in infant formula as per the mandatory regulation in the European Union. Did you ever thought what's and how the infant or toddler see in real life? We didn't think, but Davida Young Teller, professor of psychology and physiology and biophysics at the University of Washington in Seattle, thought of this. Davida is a pioneer in the scientific study of infant visual development. It was the creator of the Vida Teller cards that are used. This baby, by the way, is the grandson of the Vida Teller. And look to what studies say that the DHA and DA supplementation improves visual outcome at 52 weeks of age. Meta-analysis showed significant difference in visual resolution acuity at 2 to 4 months of age. And DHA and its glucosanoids are necessary for protecting of the retina and retinal pigment. So one may say that may be theoretical. Is it proven by studies that gums in general are advantageous? You have been talking about vitamin A, vitamin D, iron, selenium, whatever. Do you have clues? Is it fact or fake? That's 4 studies. I'll show you just 4 studies. And the references 1, 2, 3, and 4 will be in the next slide. That's the conclusion of these studies. That replacement of cow's milk intake, either by matching volume or 300 milliliters of a gum young child formula, may lead to nutritional intakes more in line with the recommendations in toddlers and young children. The consumption of gums is associated with a higher probability of adequacy for several nutrients. And micronutrient fortified gums definitely will avoid to a big extent vitamin D and iron deficiency that are common even in the West. And young children who consume gum with or without prebiotics, with or without LC-PUFAs, had significantly less reported infectious episodes when compared to cow's milk. So the summary so far, toddlers still need milk. Unmodified cow's milk has a lot of limitations that render it not ideal for toddler feeding. Gums being supplemented and fortified by nutrients and biofactors are the best nutritional options, and such factors will not only allow for optimal growth, but also offer advantages, immunity, brain development, vision, protection from micronutrient deficiencies, and definitely number 1 is not gums, it is the breast milk will never there. So if these gums are enough, no, they are enough when incorporated in a general feeding protocols or feeding atmosphere. So let's go to the rules, universal rules of feeding. The toddler and the child should be fed in a relaxing and encouraging atmosphere with no distraction. On a dining table, having a role model eating with the family, responsive feeding, no coercive feeding, and consistency, but also mealtime structure. Feed to encourage hunger, what we call hunger prompts, 3 meals and 2 snacks, minimize eating and drinking between meals, limit the length of meal times to not more than 45 minutes, feed at a chair, at a table, avoid distraction, time out for disruptive behavior, serve age-appropriate food, tolerate age-appropriate mess, encourage self-feeding, offer new foods consistently, and no forcing or nagging or threatening or bargaining. Make meal times pleasant. Don't force feed at any age. Be patient with new food and with messing. Set a good example, and don't forget the caregiver who are under pressure, particularly when they have problems with feeding. Now we have to distribute the job description. And this statement, I like it from the Cleveland Clinic about feeding the toddlers. The best thing to do is to offer a toddler variety of foods from each food group with different taste, textures, and colors. What's the job description? For the mother, she decides what food is offered, when, and where they will be eaten. And I will leave the baby to decide how much and which of the offered food. That will lessen the fights that's common between the mothers and the toddlers during feeding. And that's the recommendation regarding the different feeding groups. Fruits and vegetables, at least 5 servings each day. And you can see the servings are mentioned regarding each. For example, a quarter or a half of small fruit or vegetable is considered 1 serving. We need 3 servings of vegetables, 2 fruits, or 3 fruits and 2 vegetables. Better 3 vegetables, but 5 servings from these. Grains, at least 6 servings a day. Protein, 2 servings a day. Dairy, at least 3 servings a day, plus 3 or 4 servings of fat. That's when you ensure it. Remember, a serving is not a meal. We agreed that we will have 3 meals and 2 snacks, but in each meal, you can have many servings. Snacks are counted among the daily servings. Now, we will go to the last part, which will take 2 minutes, dealing with a picky eater. The lady on the left side is Dr. Irene Chatoor. She's a psychologist, by the way, in Washington, and she made her own classification for feeding difficulties, which was too much complicated as psychological, not a pediatrician. So Benny Kersner, the one on her side, made modification. 7 years later, he made the modification of Chatoor's classification. I was honored to meet both of them and to listen to their talks about feeding difficulties. We have 7 phenotypes of feeding difficulties. These are the 7 phenotypes. We are beyond the time, it's not the time nor the place to discuss all these feeding difficulties, but let me tell you that each one of these have different approach. So unless we handle these feeding difficulties, then gums will not solve the solution. So the take-home message, I'm sure you need to relax after all this long talk, that older infants and toddlers are not simply many others. They have their own specific characteristics and needs. They grow fast, they develop and mature. They need much more nutrients per kilogram of body weight versus adults. And at the same time, they have small tummies, and unfortunately, feeding difficulty starts here. It's sometimes quite difficult to achieve optimal supply because of things related to the toddler, to the nutrition, to the parents, and to us. Time constraints. The unmet nutritional challenges resulted in a high prevalence of malnutrition clinical syndromes, whether stunting, wasting, overweight, iron deficiency, vitamin D zinc deficiencies in all our region, Middle East and Gulf. Not only our region, but also all over the world. Milk and dairy products are important sources for calcium and protein for the fast-growing toddlers, but unfortunately, the unmodified cow's milk is not suitable for these kids. So we need to add the value by using the gums for those who can afford it. The toddler's diet should be well diversified over 3 meals and 2 snacks and offer the appropriate number of servings. Parents need to apply the basic principles of feedings and rules of mealtime structure, and we need to deal with the possible feeding difficulty. Whenever possible and affordable, never compromise on quality, because our toddlers and young children deserve the best possible nutrition. Thank you very much, and sorry if I took much time.
As usual, Dr. Blady, very engaging. You can take as long as you want. We will be listening. Thank you so much.
Thank you. Thank you.
We have probably lots of questions, but thank you so much for the very elegant presentation. You placed the toddlerhoods in a probably different place in our minds after this very elegant talk. Probably we understand how toddlers are different from infants, how toddlers are different from older children. So it's a nice way that you've taken us through the toddlerhood and how the challenges and how the opportunities that we have with them at the current time. So hopefully we go through all the questions and we get the chance to answer each and every one. Probably we had lots of questions today. Thanks to the audience and thanks for them to bring up these points to discuss further. So one question was about vitamin A deficiency.
Yes.
Do you know the number in Saudi Arabia? Probably, I think you left the link so that anyone can check it.
I can go to the slides if you want. But of course, I cannot recall all the numbers, but I can share the screen with you, and we can go back to the numbers if they want exactly the vitamin A in Saudi Arabia. Just I'll go.
We can take a short quiz. Yani, we can post quick questions for the audience to answer them.
Okay.
Until we come with the exact number, if we have it, or it's available.
It's available, sir.
Yeah. So we can shoot the questions now.
Okay, that's the vitamin A deficiency in the different countries. Saudi Arabia is less than 10%, like Egypt and Libya and Tunisia and Emirates and Oman.
Perfect.
Less than 10%. So they are in the best category.
All right, so we're ready to put the...
Go for the quiz, whatever you want.
Quiz, then we resume the questions.
Yes. The admin should go to the quiz. I can't.
Yeah, we're waiting for the quiz to come up.
Okay.
So in the quiz, answer fast, answer correct, receive your gift. هيطلع حالا يعني we're coming up with the quiz now. Just give us 2 more seconds. Okay, so we keep the questions until the quiz is there. There is another question. Do you recommend giving vitamin D routinely in toddlers above 1 year, from 1 to 5 years?
Well, that's, you know, I'll tell you the recommendation. The recommendation is that you will continue vitamin D till the age of 1 year. And then they mention that food is the main source of vitamin D because the sun, with the recommendations, whether of the American Academy of Pediatrics or the American Academy of Dermatology, we are not questioning that the sun can produce vitamin D if you are skin exposed, but there are many intervening factors that they still believe that food and diet is the main source. So they said that you may, that's their own statement, you may need to give it for the toddlers and for the kids. Of course, if they eat a vitamin D fortified gums, for example, or vitamin D rich sources, fatty fish or something in enough quantities, then you may not need to supplement. But again, you need to observe, because we do not need to pass through vitamin D insufficiency in this era where vitamin D is linked to almost anything.
Okay, and at what age would you recommend to start vitamin D supplementation, if any?
I start vitamin D supplementation for the breastfed after 1 week. In fact, they said the first few days of life. So I usually start after 1 week to be sure that everything is going fine. I continue till the end of the first year. And according to how the baby is eating and whether he's a picky eater, he's taking top quality formulas, or I supplement many of the kids. and I'll continue depending on the history of the nutritional history. So there is no black and white here. There is no age that you should start and you should stop.
Yeah, perfect. So there's another question from Yemen. I think, I don't know, he's asking about the reference for the 82% anemia in Yemen. Maybe
I'll tell you, this is one of the great references. You just go for this one.
Yeah, all countries are there, I think.
Yes, all countries are there, and you go by country, by the way. That's Nutrition Landscape Information System of the WHO. And when you go there, you will find by country. So you simply go to your country, whatever the country you want to go. They not only they will tell you the percentage, but they will tell you the year of the reference, because this is Access 2020, but the data from all of these countries are from 2016, and you will find the reference from Yemen. And if you go to Sudan, you'll find the reference from Sudan. So I'll take you back. You can photo this. That's the reference. WHO, and it's Access this month.
Perfect. There is another question. Do you face teeth discoloration when giving iron supplements? And how can we prevent it?
What type? Teeth discoloration.
Yeah, teeth.
I'll tell you, to be honest, I don't give iron supplementation so frequent. And the question is why. Iron is bad if there is overdose of it. So we have iron toxicity, not only acute, but also chronic. So I encourage iron rich food, iron rich cereals, iron fortified cereals. Gums are iron and vitamin C fortified, so I'm confident of the bioavailability to a big extent. We all know that red meat and liver and whatever, and the toddler can eat all of this. And I don't give iron supplements unless I do a hemoglobin and serum ferritin and CBC, and I'm sure that I'm dealing with iron deficiency anemia. There is another way that the WHO mentioned in 2016. They divided the country about the iron, the anemia as public health significance. And if your country having severe public health significance, which is 40% or more, and by the way, Egypt was in this category till very recently. We moved to a lower category, which is moderate public health significance. They have recommendations, special recommendations for each category. For the countries who have severe public health significance, they recommend a recommendation with the special dose for each age, and that's WHO recommendation. For moderate, they recommend 3 months, 3 days a week for 3 months, while for iron, they recommend 3 continuous months over the year. So each country will have. For me, I don't follow my country. I don't follow this. I follow the individual. I ask my patient at the age of 1 year to do hemoglobin, serum ferritin, CBC to check, and if he's iron deficient, definitely I will use iron preparation.
Okay, great. There is one question regarding omega-3. Does it have a role in improving toddlers' appetite?
Well, we are sure that the DHA is related to mental development, to visual development, and to immunity. We are sure of that. Data, science says so. So far, unless the science changes, but at least today, but I didn't pass through that the omega-3 would improve the appetite. Maybe, but I don't know.
I think we have another comment from Yemen as well regarding the anemia. They saying it does not exceed 74%. So probably different references give different
No.
ratings,
The reference is very clear. Just
yeah,
go
the one
to
you
the
shared,
landscape, and definitely the figures are correct. Definitely. In the last year, by the way, I used to give a similar talks. By the way, the numbers were different. Yemen was 63%. When my talks last year, the Yemen was 63%. But I always, before I make, regarding the numbers in particular, I go to this website to take the most recent data. And please let him check the anemia below the age of 5 years or under 5. And he will find the number that I mentioned, 83.5.
Okay, so we have one more question.
Okay.
Do you have a comment regarding genetically engineered foods and organic foods?
Well, there is always a lot of debate about this, okay? Studies say that organic food may be better, less pesticides. Some studies showed there is no differences. I think my enemy is not the food, whether it's organic or not. In our countries, we have wasting, we have underweight, we also have overweight because of bad feeding practices. But we have anemias, we have the micronutrient deficiencies, and of course, sub-Saharan Africa are worse, and some parts of Southeast Asia are worse than we do, but we are not doing fine. When the WHO says that in Egypt, 31% or 32% of the kids under 5 are anemic, that's not something to be happy with. So it's not about, part, by the way, of these issues are related to the income, not only to the nutritional ignorance, but it's also related to the poverty. And we need to give affordable food. So if organic food is so expensive, I wouldn't go for it. I would go for food, stable food that's available, affordable. And when we say, for example, don't use cow's milk, we say that the top quality gram formulas, for those definitely you can afford it. And in some countries, everybody can afford it, by the way. Other countries, if you can't afford it, then you will go to basic formulas, but definitely will not go to cow's milk, because unmodified cow's milk is a real nutritional disaster.
There is also a comment from Dr. Iman. Do you advise sun exposure from 9 to 10 a.m.? What time do you recommend due to direct penetration of ultraviolet?
Well, after I heard the American Academy of Dermatology, and by the way, this tweet is this month. It's not last month. This tweet, the one that I mentioned, I called my daughter and told her, when you take your my grandson to the sun, please put him with a long sleeve. She said, my dad is crazy. I said, that's the American Academy. It's not me. So they keep recommending, and they recommend to use the sunscreens, the sunblocks. And they said, although it's not advisable below the age of 6 months, but if you couldn't put him in the shade and couldn't do the other measures like the clothes that cover him totally, long pants and long, then you can put sunscreens with an SPF not less than 30. So they are taking the issue of the sun seriously. And they insist that the main source would be nutrition. That's not only the American Academy of Dermatology, but also the American Academy of Pediatrics. Definitely it is not a big loss to put him in the sun, direct sun. If the weather is good and you are sure that he will not have sunburn for short time, but I wouldn't depend on it. I wouldn't rely on it, because both medical bodies say don't rely on it.
There are some questions regarding picky eaters.
Yes.
And one of them was, how can we encourage picky eaters to eat healthy food?
That's a very complicated question, because picky eating, as I mentioned, there are at least 7 phenotypes. And each one has an approach, behavioral approach and nutritional approach different than the other. Probably there are some facts, the rules of eating. If you fight with the picky eater, you will lose the war, 100%. Fighting and force feeding is not recommended whatsoever. The food supplements, the high-calorie food supplements, all the nutritional companies do them, and that's part of the management. It is not the whole management plan. It can help as a part of the management. And then the playful management is quite different than the apathetic management, is quite different than the selective. And Tawfiq, we can do another webinar for the picky eating only, but I can't because that's, by the way, I attended a course of 8 continuous hours over 2 days. No, for 16 hours.
It's a long story.
For the picky eating only. So it can't be summarized. But we are sure that if you force feed a picky eater, you will lose.
Perfect. There is another question on, would you recommend at what age vitamin A supplementation and at what dose, if any?
Well, the WHO again recommended that at the age from 6 to 12 months, one supplementation with 50,000 international units of vitamin A. Then between 12 months and 5 years, they recommended 2 supplementations, each is 100,000 international units. I had some slides, I removed them because of the time, but I can show you in a second if you want that the supplementation is not doing great. These are the slides, I'll show it to you. This is the one. That's the vitamin A deficiency, puts 140 million children at risk of illness and death. And look to the supplementation. Today, more than 1/3 of children in need are not receiving the life-saving benefits of vitamin A supplementation. So because of the time, I have to remove many of the slides, by the way. But
before we think of supplementation, we think of fortification, and we think even before fortification of balanced diet at some point of time.
But by the way, these supplementations are mainly designed for our countries, for many of the poor countries and unprivileged countries, because if you are taking good quality milks, we all know that the milk is rich in vitamin A. So if he is eating well diversified food, we don't have a big problem with it. But the numbers, as I told you, there are many countries. Here is the numbers.
There is another question. There is another question. Oh, okay. We have lots of questions today, so probably we have to run fast.
Yes.
Do you recommend zinc during the COVID supplement?
The COVID is a real therapeutic disaster because nothing has been proven, and all of the medications that have been mentioned are either off-label use like azithromycin or compassionate use like remdesivir or whatever, or plaquenil, which was withdrawn from many countries as compassionate use, so the off-label use. One of the theories that the zinc, high dose of zinc and vitamin C can interfere with the entry of the virus and viral replication within the cell. Do we have data? Unfortunately, this virus is a novel virus. It's part, the zinc supplementation, vitamin C in high doses is part of the protocol of management in my institution. Do we have a scientific basis for this? No, theoretical basis. COVID, unfortunately, the treatments are all compassionate or off-label.
Okay, there's another question regarding fiber intake in toddlers. Do you advise giving extra fibers, or you leave it to the diet?
We encourage giving a diet rich in fibers. And if we is talking about prebiotics, yes, it's definitely an added value. I didn't go in details in prebiotics and probiotics because I know that this is a big talk in itself to talk about prebiotics and probiotics. its nutrition can't be summarized in 1 hour. For example, I think your gum, your Nido 1 Plus gum, contains Lactobacillus rhamnosus. I know, but I didn't pass through the probiotics, for example. The fibers and the prebiotics, they have a role. There is nothing called give extra fibers. Nobody will benefit if he takes enough fibers, and enough fibers for this age, not more than 5 grams. If he takes them per day, that's well and good. He will not benefit from extra fiber.
Do you fear hypervitaminosis D or hypercalcemia with vitamin D or calcium supplementation?
Very rare to happen unless usually iatrogenic by miscalculation or misunderstanding of the mothers. For example, there are the shock therapy where we give sometimes injection of 200,000 units or even worse, the 600,000 international units for injection, and some parents take them and they think that they need to be given on daily basis or whatever, and here we can see hypervitaminosis D. I didn't see hypervitaminosis D comes from a doses like we mentioned, 1,000 units a day or 600 units a day. I didn't see it.
Okay, there's another question. When should we check from a laboratory side the micronutrients, or should we give multivitamins routine?
All comes within the frame of the nutritional history. If I take a good nutritional history and I found there is excellent diversification of food, that he is taking the servings that we said about, he is taking good vegetables, good fruits, cereals fortified, top quality milks, and if the diet is that clear, then I don't do any lab test as long as the child is healthy. There is no recommendation that you should do lab finding to check for vitamin D or for selenium or for even zinc or whatever for finding shortages. But if a child is not doing well from the nutritional history or from examination, the history, if the mother tell me a history that points to a bad eating habits and bad quantities, then at that time I would go to ask for these labs.
In a few minutes, we'll be putting the quiz, so be with us. And there are many questions. There is a question from Dr. Omar, why unmodified cow's milk causes hemorrhagic enterocolitis while growing up milks don't? Do you have an idea on that?
No, I know, I'm sure that unmodified cow's milk causes bleeding. They mentioned the amount of blood loss with fresh cow's milk is 7 times the blood loss in other types of milk. Both of them are occult blood loss, but using cow's milk, the fresh animal milk has been linked to anemia due to blood loss, which is iron deficiency anemia. I'm not talking about cow's milk allergy. I'm talking about an infant or a toddler who's receiving cow's milk. I'm not sure of the mechanism. I didn't pass through mechanism, maybe related to the macronutrients, how they are tough on the mucosa, but I didn't pass through the explanation.
Perfect. There's a question about constipation in toddlers. Is there something in specific that needs to be done to overcome it?
Oh, that's again one big talk about what we are sure of, that the so-called give him too much water, it doesn't work if he receives what he should receive from total. The fluid intake is normal. Also, among the common mistakes, give him too much fibers, because if he is receiving the fibers appropriate for his age, extra fibers wouldn't work. What we are sure of, that we need to identify if there is organic cause, and one of the organic causes can be cow's milk allergy, by the way. But we need to exclude organic causes, and if we exclude organic causes, we need to ensure evacuation of the rectum, because if we left the rectum is distended, if we leave it, it will lose the sensitivity to contract later on, and the problem may be lifelong. So while we all know that functional GI disorders, the pharmacotherapy comes very late, if any, the only exception is constipation, where we are allowed to use laxatives to avoid the changing from a transient issue to a long-term issue. So extra water will not work. Extra fibers will not work. Many studies about pre and probiotics that can help, may help some individuals, softer stools, maybe. Definitely evacuation by laxatives like lactulose is recommended.
Okay, great. There is another question about the chronic iron toxicity features and how can he manage it, from Dr. Nazmi, I think.
But I prefer not how to manage. I don't want anybody to go into iron toxicity, the chronic form of the hemochromatosis, when the iron get deposited into the different tissues, including the liver, the skin, pancreas, endocrinal glands, and he can suffer from diabetes, he can suffer from myocardial even dysfunction. So we need not to go for this, and that's why, unlike vitamin D, the iron supplementation is recommended only after good evaluation of the hemoglobin, CBC, and serum ferritin. When you do serum ferritin, because it's an acute phase reactant, you should do CRP, because if the CRP is elevated, then an elevated serum ferritin is not an index of iron stores. So we need to dig before we give iron supplementation. It's quite enough the iron fortified food, but to dig deep into the iron before giving supplementation to avoid too much iron.
One more question about iron. Do you recommend routine iron supplementation after the age of 6 months?
No.
Okay.
I don't recommend the routine.
Yeah.
If the baby is preterm and he was sick in an incubator where a lot of blood samples, and yes, we start iron supplementation 1 milligram per kilo elemental at the age of probably couple of months. You know that the babies are born polycythemic, and then they degrade their RBCs, so they have iron stores. If they are healthy babies, they have iron stores enough for at least 6 months. And by 6 months, you start complementary feeding. And if you ensure iron-rich cereals or iron-rich food, you will not need routine supplementation.
Perfect. There's another, probably this will be the last question that we take. Then we will start the quiz, and hopefully the winners will receive their gifts. So one last question about the appetite assessment. When would you say that this is a reduced appetite in a toddler? And is there a place for any medication to improve the appetites?
Well, the second part is the easiest. Definitely there is no place for any medication, okay? The appetite stimulants or whatever, that doesn't exist, okay? So how to assess the appetite? Sometimes from the history, from the mother, sometimes we ask for a food diary of over 1 day or 3 days, and food diary needs to be described well to the parents. We need to invest in time, and food diaries, they need to write anything that enters their mouth. Even sometimes I tell the mother, if your child by accidentally aspirated a fly, mentioned to me that he ate a fly because I wanted not to miss anything. And through the dietary, the daily diary, again, there is also a food diversity score and a diet diversity score and food variety scores, but I'll go simple with the food diary and check which types of servings are given. I depend, in fact, on the Cleveland Clinic few slides that I mentioned. I give them to the mothers and I tell them about these are the servings. You need to tell me exactly what he eats. With a 3 days food diary, although it's not easy with everyone, I can avoid the over statements of the parents that the child is not eating well. Of course, monitoring the child over the growth percentiles, and I can see if he's deviating down, the attitude of the child, and we can dig deep about the 7 phenotypes, because sometimes the problem with the feeder and not with the baby. So you can assess with the dietary feeding diary, you can assess with a good history taking, and definitely with monitoring of the child.
Thank you so much, Professor Ahmed. Yani, Dr. Bledi, we still have some more questions, but probably we're bypassed the time long ago. We'll be shooting the quiz now for the attendees and participants to give a shot. Then we'll be having the final remarks from your side before we close.
Just last minute, I have to leave, Mohammed, because I have another webinar in Egypt. It will start at 8 exactly, 8 my time, which is we are coming there. So, and regarding the reference for the Yemen, if my dear colleague couldn't find it, please let me know so that I can send you a screenshot where he can find the reference. And thank you very much for you all, for Nestle and for my attendees with excellent questions. And please let me reassure you that not a single slide was not referenced. So if you are in doubt of any single data, just we will send you the reference and you will find the data. And thank you very much, Mohammed, and all our colleagues.